Well, let's continue talking about specific toxins. Now I'd like to speak to you about alcohols. And I don't mean ethanol, the active ingredient in beer and wine and whiskey, but I mean the toxic alcohols. Specifically, I want to talk to you about methanol, ethylene glycol, and isopropyl alcohol. There's always a question or two on the test. So why do people drink these? They drink them because you can feel drunk from them. However, they have worse side effects than ethanol, ETOH. Okay? So the patient with a toxic alcohol ingestion will appear drunk, but their ethanol level, ETOH level, if you checked it, will be 0. Okay? And the key thing to remember in these poisonings is that the toxic metabolites of the methanol and ethylene glycol and the isopropyl is more damaging to the body than the parent substance itself. Okay? Secondly, all three of these substances are metabolized by alcohol dehydrogenase. And they're metabolized by alcohol dehydrogenase into more toxic metabolites. So we're going to learn if we can block alcohol dehydrogenase, then the toxic metabolites are not formed, and eventually the parent compounds, the methanol, ethylene glycol, and isopropyl alcohol can slowly be removed from the body. Okay? All three of these poisons are absorbed rapidly from the gastrointestinal tract. This makes the use of gastric emptying of very little value, okay? Because by the time the patient gets to the hospital, it's already absorbed. As soon as this material is absorbed into the bloodstream, it gives you an osmolar gap. These are osmotically active substances. All right? As methanol, ethylene glycol are metabolized, the osmolar level comes down, and these are metabolized into an acid. So the patient develops a metabolic acidosis as the toxic metabolites are formed. Okay? Isopropyl alcohol, however, is metabolized into ketones, acetone. So in this case, isopropyl, the patient will not have a metabolic acidosis. They will have ketonemia, but no metabolic acidosis. All right? These materials are present in several different products. Isopropyl alcohol is rubbing alcohol. It's also seen in varnishes and paint thinners, jewelry cleaners. Methanol is a typical substance that's found in window washing fluid for the cars, as well as sterno and certain varnishes. And ethylene glycol, that's the stuff that's typically in your car for antifreeze. These materials are mostly ingested. However, keep in mind that isopropyl alcohol and methanol can be inhaled as well. And methanol can be absorbed through the skin. Isopropyl alcohol can be absorbed through the skin also, and the classic case is that of an infant with a fever. And if the parents are using isopropyl alcohol to sponge down the infant and bring down the fever, isopropyl alcohol poisoning can result. This also has implications for treatment, and that again, this is a situation where protecting yourself first with appropriate clothing so you don't inhale or absorb the poison yourself is important. Ethylene glycol is only absorbed through ingestion and not through the skin or inhalation. This graph demonstrates the toxic breakdown products of each of the parent compounds. Isopropyl alcohol is broken down ultimately to acetone. You can remember that the target organs are basically brain and gastrointestinal bleeding. And as I mentioned earlier, there's no metabolic acidosis formed. Okay. In this particular substance, you do not treat with alcohol or formimazole. I'll tell you what those are in a second. For methanol and ethylene glycol, methanol is broken down into formaldehyde. Well, that can't be good for you. And formic acid. The target organ is the eye first. You'll always see, or frequently see in the question, that the patient presents with snowfield blindness. Looks like a television screen with static. Okay? This will develop a severe metabolic acidosis, and we do want to block the formation of the formic acid with the use of ethanol or fomepizole. Ethylene glycol is broken down into oxalic acid. The target organ is the kidney and causes kidney failure. Okay. This also causes metabolic acidosis. And again, we're going to prevent the formation of the acid by the use of alcohol or fomepizole. I've listed a couple vitamin cofactors, and they might ask you a question about what vitamin cofactor is responsible for the excretion and breakdown of methanol, and you'll say folate. So giving some extra folate in methanol is useful, and giving some extra thiamine and pyridoxine in ethylene glycol toxicity is useful as well. The alcohol, ethanol, ETOH, or fomepizole, remember, that is going to block alcohol dehydrogenase, and that prevents the toxic acids, the formic acid and the oxalic acid, from being produced. What is the osmol gap? An osmol gap is the difference between the measured serum osmolality and the calculated serum osmolality. So you order a measured serum osmolality, and they'll give you a number, and you go ahead and you calculate the serum osmolality, what it should be, based on the serum sodium, the serum BUN, the serum glucose, and the serum ethanol, all of which can be easily measured. These two numbers should be equivalent. If they're not equivalent, there's some unaccounted for osmols in the serum, and those are going to be one of the following substances: isopropyl, methanol, ethylene glycol, and it's usually pretty obvious if the patient's received mannitol. Okay. The purpose of this slide, you don't need to memorize this whole thing, is that a little bit is very dangerous and that it's rapidly absorbed, making the gastric emptying a futile effort in this type of poisoning. With isopropyl alcohol, the patients have nystagmus, and frequently you'll have a history of that they're vomiting blood and having abdominal pain. They could also have renal or liver dysfunction, and severe cases present with CNS depression and eventual hypotension, hypoventilation, and death. The ketones that are formed makes the person have ketonemia. And you just differentiate this from diabetic ketoacidosis by the fact that the serum glucose in these cases will not be elevated. And they do not have a severe acidosis, but they do have ketones in the blood and in the urine, just like diabetic ketoacidosis. So the ABCs, well, we take care of that on everybody we meet. No gastric lavage as a rule because it's too rapidly absorbed. Don't bother with charcoal. It doesn't absorb to charcoal either. You can do hemodialysis if they're very, very ill with unstable vital signs. For patients with maybe just a sip of isopropyl alcohol, if they remain asymptomatic for 4 hours, they're probably going to be asymptomatic for the entire time, and they're not going to be seriously ill from the ingestion. Don't need to memorize this slide. The take-home point is the same, is that it's rapidly absorbed methanol, and that a little bit can be fatal. Methanol, people drink it because they get drunk, just like ethanol, right? The initial problems people complain of is abdominal pain with pancreatitis, and they complain of visual changes with double vision, that snowfield blindness we talked about, and nystagmus. Ingestions can cause basal ganglia infarcts as well, and they could have long-lasting CNS effects. Patients can look like they have Parkinson's type symptoms after a single methanol ingestion. So this is nasty stuff. The treatment for methanol, supportive care like everybody else. Again, gastric lavage and charcoal is of limited to no use. We're going to give the folate to help eliminate the poison. And we're going to give either ethanol or fomepizole to block the alcohol dehydrogenase, to block the formation of the formic acid. Okay? It's either or, fomepizole or ethanol. Lastly, if the patient's very ill, this is a dialyzable molecule, and you should call the nephrologist for dialysis. Ethylene glycol, this is a very sweet kind of substance, and like the other substances we talked about, rapidly absorbed. No, gastric emptying won't work. It's too late. Charcoal won't work, and the main target organ is the kidneys, causing kidney failure. Again, a little bit can be toxic and cause death. With ethylene glycol, we think of 3 phases. But you know what? These 3 clinical phases overlap, so a patient with ethylene glycol can have any number of these symptoms together. First, they're going to appear like they're drunk. They might be slurring their words a little bit, and they can be have so much CNS depression that they're in coma, or even it can cause seizures. Okay? They won't complain of any blindness. That's methanol. Remember, if you look at the optic, if you look at the retina will appear normal. If you look at the retina and methanol poisoning, you might see some hyperemia. The second phase of ethylene glycol intoxication is they call it the cardiopulmonary phase classically. That's 12 to 24 hours. And this is increased heart rate, increased blood pressure, increased respiratory rate. They're short of breath. They may have a ARDS, acute respiratory distress syndrome type picture. Finally, the third phase, 1 day to 2 days later, they're going to have flank pain, CVA pain, and acute tubular necrosis. They may have symptoms of hypocalcemia because the oxalate acid combines with calcium to form calcium oxalate crystals in the urine. So if they give you a UA and it shows calcium oxalate crystals in the urine, one of the things to consider was this an ethylene glycol intoxication? Remember our principles of treatment? It's ABCs, supportive care, right? Right? So if this patient is severely acidotic, you would give bicarb. If this patient is severely hypocalcemic, you would give IV calcium. Thiamine and pyridoxine help remove and metabolize ethylene glycol. And again, we want to give the ethanol and the fomepizole in this case. I should say ethanol or fomepizole to block alcohol dehydrogenase. That will prevent the formation of the acidosis. This is another dialyzable substance, and for severely ill patients, dialysis is indicated. So which drug do I use to block alcohol dehydrogenase? Do I give ethanol, ETOH, or do I give fomepizole? And basically, the ETOH has the advantage of being cheap and readily available. Usually what they do is, in the hospital setting, they mix up a 10% solution of ethanol and give it as a continuous IV drip. And you're shooting for an alcohol level of between 100 and 200. That's like 0.1 to 0.2 if the police pull you over. So that's pretty drunk. So the disadvantages is that it can cause hypoglycemia and can cause even more CNS depression. So this really isn't something you'd want to do for children, particularly. The fomepizole, the advantage is that it's just an IV shot, and the only real disadvantage is it's not on everybody's formulary since it's quite expensive. So my approach would be, if fomepizole is a choice, go ahead and do that. And if they don't have fomepizole as a choice, go ahead and use the ethanol. All right. When do you add dialysis in addition to giving the ethanol or fomepizole? And that's basically the people who are getting sicker and aren't getting better. You could memorize the list, or you could just remember people that are getting sicker. It's a lot easier. So severe acidosis, someone that's seizing, someone that's in coma, someone that's in renal failure, someone that's in intractable metabolic acidosis. If the patient's looking sicker, go for dialysis. That's the end of toxic alcohols. Thank you.